Make it full screen. We'll just check if it is being full screen. You can make it full screen.
Thank you.
You can go to slideshow and make it full screen. Yeah. Okay. We'll just wait for 2 minutes. Dr. Vishnu will be joining in a couple of minutes.
Hi, Drija.
Hello, ma'am.
Do you have stable connection, net connection?
Yes, we are in research.
I hope so. I think you are sitting in doctor's room, right?
Ma'am, we are in research unit.
Research. Then it is stable, very stable.
Dr. Vishnu will be joining shortly.
Drija quickly agreed at the last minute, actually, just 2 days
Very
back.
nice of her. Very nice of her to come forward, because we had couple of institutions who were due to present, but there were problems at their end, so they could not. And then I asked ma'am, and she readily agreed. So very thankful to Oti ma'am also.
Not at all. I think that many people have helped her, except me. Who are the faculty today, other than Ambike madam?
Yeah, we have Dr. Biradar, Vishnu Biradar.
Okay,
He will be
great.
joining in 5 to 7 minutes. He's busy with something. He said he'll join as soon as possible.
Oh, I see. So Vishnu and Madam Ambike Madam Deepa.
Yes. Next time we have Bharti, and after that we have AFMC. It is good to see non-CNS cases being presented. I think we had quite a lot of CNS discussion.
Hello, madam. Good afternoon.
Hello.
Hi.
Madam, there is some echo from your device.
Yeah, actually, even I am getting echo when you people are speaking.
Okay.
You can switch off and switch on. Will it help?
मगाशी तुम्ही आणि होती मॅडम बोलत होता ना, तेव्हा पण इको येत होता.
Okay.
इथं
Are you
दुसरा
on two
कुठला
devices,
device
madam?
चालू आहे का?
आता
Are you
पण
on two
येतो.
devices?
नाही, माझे दोन नाही आहेत डिव्हाइसेस.
मल्टिपल डिव्हाइसेस ऑन असले की येतो.
नाही, माझा मोबाईल नाहीये.
I can see 2 devices against your name in the panel list.
Okay. Okay, I will log in again.
Yeah, sure. Okay.
Yeah.
Sarita is there?
Yes, ma'am. I'm here, ma'am.
Hi, Sarita.
Yes, ma'am.
We'll just wait for 1 more minute and then we'll start. We have attendees are joining in.
Mishra sir had not received the link. I had
I
asked.
had messaged him and called him also.
Yeah, even I have just confirmed that he's sending and sir is joining maybe in some 2 minutes. Yes.
I had called him, I had messaged him, he's not shared his email ID.
I have
I'll
just put
send
it.
him
Yeah.
a direct link
Yes.
to join.
Yes, sir. Yeah.
I have sent him a direct link.
Okay, sir.
Shall we start? I think we have waited for 5-6 minutes.
Yeah, I think so.
Are we live?
Yes, we are live now.
Okay. So on behalf of IAP Pune, it gives me great pleasure to welcome you all for this 8th case presentation this year of IAP PG Clinic. And today we have Dr. Drija, who will be presenting a case of hepatosplenomegaly with abdominal distension. And she's a resident from KM Hospital, Pune. Dr. Drija, please start the case.
Good afternoon, everyone, and happy Guru Purnima to all of you. I am presenting today's case of hepatosplenomegaly with abdominal distension. My name is Dr. Drija Patel from KM Hospital. My patient is a 10-year-old female child named Aliza Inataya Qureshi, residents and hailing from the Gulbarga, Karnataka, Muslim by religious, born of third-degree consanguineous marriage, first by birth order, informant being mother and reliable, brought to the KM hospital with a chief complaint of first, abdominal pain since 1 month, second, vomiting since 1 month, third, yellowish discoloration of eyes and skin since 10 days, and fourth, progressive body swelling since 8 days. Origin, duration, progression. The child was apparently asymptomatic before 1 month, and then she started having the abdominal pain, which was insidious in onset 1 month ago in right upper part of abdomen, continuous, dull aching, moderate in severity, aggravated by the posture and physical movements like standing or walking, relieved by resting in lying down in supine position. The pain was gradually increased over 7 days. And she has to taken treatment for it, and after treatment the pain was relieved, and then again it will reappeared. After 24 hours of the abdominal pain, she started having vomiting, which was acute in onset, associated with the nausea. Initially, yes,
What's your first name, dear? What's your first name?
Drija.
Drija, can I interrupt you in between?
Yes, ma'am.
Drija, regarding the pain, abdominal pain, you have classified into moderate, right? The severity of the pain is moderate. So, is this the way that we classify pain? Do we say there is mild, moderate, severe, or is there any other classification of pain which you can, like put it up in the chief complaints? What do you understand by moderate?
Ma'am, it was not that kind of severe that she has to take treatment immediately. She was crying with the pain, but it get relief, kind of relief in the supine position.
Can you tell it in a better way? Can you distinguish it from mild? That how did you know that this is not mild? You said that she did not need to take immediate treatment.
Yes.
That is her version, right?
In mild, if it was mild, then she didn't has to attempt to relieve it, like in has to lie down or anything. And crying is not there in the mild pain.
Was she going to school when she had this pain?
So for the vomiting and abdominal gate pain, she was admitted outside, and after the admission, the parents were not sending the child to the school.
See, Trija, whenever the pain interrupts a routine physical activity of a child or an individual, it is no more a mild pain. Okay, so you're right, you're putting it as moderate, but you should know, is this the way that we modify pain? Because there is a new scale for pain which is given. Nowadays, we don't classify pain as mild, moderate, severe. It has some other scale. Okay, so actually the scale is based on smiley. We use those smileys, you remember, for WhatsApp?
Yes,
So that's a pain scale which is
pain
given.
scale.
Yes. So if you can put it in that scale between 1 to 9 or 1 to 10, it would be better. Okay. And then you can tell me that yes, you can say it is moderate, but based on the pain scale. Fine.
Okay.
Yeah. Okay. You can.
It is called as Likert scale, Dr.
Yes. Yes.
Rishi. It's called as Likert scale.
Yes.
Then after 24 hours of abdominal pain, she started having vomiting, which was acute in onset, 2 to 3 episodes per day, non-projectile, containing the food particles associated with decreased oral intake, not associated with the blood or bile in it, loose stool or constipation. The course of vomiting is same of the abdominal pain. It for the 7 days, it increased in the severity, and then on oral medication it was not relieved, so child has to get admitted for it, and some investigations were done, IV medications were given, and during hospitalization the symptoms were relieved, so oral intake improved, the child discharged from hospital and remained asymptomatic for 10 days, next 10 days.
If you were the treating doctor, what would you think of abdominal pain and jaundice? What would you think? And vomiting, what would you think of?
So it could be related to gastritis, but it is more of the right side. So I would think of it as a hepatitis, but there is no history of fever.
Ambika ma'am, you want to ask something?
If the vomiting would be associated with constipation, what would be your version? Suppose there was no jaundice and the baby has come with vomiting and constipation.
Then it could be UTI.
Vomiting and constipation.
What is the age of the child?
10 years, sir.
So you think a 10-year-old child will come with constipation, with UTI, without urinary symptoms? No, and UTI again, fever will be a predominant
Fever will
symptom,
be
isn't
there,
it?
and
So this is an afebrile illness where there is abdominal pain and vomiting. And madam has added one more symptom, constipation. Child has not passed stool. So where will you get this symptom complex of pain, vomiting, and not passing stool?
obstruction.
Yeah, very good.
Yes,
Obstruction.
Yes, very good, very good. Okay, you proceed with your case.
Day 10 after the discharge, mother noticed yellowish discoloration of urine and eyes initially, which was progressed to the skin all over the body, palm and sole over the next 4 to 5 days. It was associated with a dark color urine and yellow color stool, not associated with itching. Yellowness is gradually increased over the days, and when the child was admitted, it was dark yellow. And on the day 5 of admission in our center, after getting the treatment, yellowish discoloration visible in the only in the eyes and decrease over the skin. After 2 to 3 days of the jaundice, mother observed there is a swelling on the both legs, which was progressed to the both eyes. It was almost same throughout the day, not associated with diurnal variation. On the next day, abdomen started appearing distended, not associated with any movement restriction or difficulty in breathing. She was able to do all the routine activities, not associated. It was not associated with postural or diurnal variation. So for the same complaints, they consulted outside to the local doctors and referred to our center for the further management. After the admission, Swelling is still there. When I examined the child, swelling was still there around the eyes, legs, and abdomen, but it was a decrease than the previous ones. There is a history of weight gain of 2 kg in last 20 days. There is a history of weakness, decreased activity, and easy fatigability.
Brija, you just said that the intensity of the icterus decreased over course of time. Can you just go back to the slide of jaundice? Yeah. You have said that it decreased over the skin compared to the previous one. I didn't get this. Means what happened exactly?
Ma'am, initially, when child was not admitted, now the jaundice was increasing on severity, but after getting the treatment, it started decreasing.
Can you tell us what type of treatment did she take? Was it from allopathy or from some other medicine? Usually they go to some other quacks also. Did she go somewhere?
They went to the local doctor, ma'am, but they referred to higher center.
So is this normal, Trija, that the icterus will decrease over the skin compared to previous one and it will increase in the eyes? I mean, first time I am hearing something like this.
No, ma'am. In our center, we have done treatment, and in that course, on the day 5 of admission in our center.
Okay, that is what you wrote in your hospital.
Yes.
That is
Not
after
outside.
getting treatment.
Yes.
Okay, can you highlight on the drug history then what type of treatment did she receive over the 5 days? Are you going to tell that later?
Ma'am, I'm going to tell that in hospital course.
Okay, fine.
Negative history. No history of prolonged bleeding after the putting intracath or in the form of blood in urine, stool, or vomitus, or in the form of petechiae or purpura. No history of emotional lability, depression, poor scholastic performance, or change in the sleep cycle. No history of abnormal movements of hands, tremors, or change in the tone of muscle. No history of any visual problems, limb deformity, of excoriation of skin. No history suggestive of fever or any prodromal phase symptoms, and recovering completely from that symptoms. No history of fever with autoimmune disturbances like involvement of the mucocutaneous or mucoskeletal system. No history of previous blood transfusion. No history of similar complaint in past or in any other family member. No history of chronic drug intake.
Brija, just go back to the last slide of negative history. No, yeah. So that first thing what you are mentioning, there is no history of recovering after appearance of jaundice. I didn't get this. What do you mean by that?
Ma'am, I want to exclude the hepatitis. Initially, there was a prodromal phase symptoms like nausea, anorexia, vomiting, and after the appearance of jaundice, the symptoms started decreasing and child's oral intake is improved.
Okay, fine. Can you name some?
This is what typically happens in viral hepatitis.
Yes,
Viral hepatitis
that is not the case here. That is what you're saying.
Yes.
Now, before you go to the negative history, you need to make a diagnosis, isn't it? Based on your history, you need to think of what system is involved. In that, what is the microanatomy? What pathology is there? So what was your thoughts when you completed your positive history?
So, from my history, I would make out there is an involvement of the liver. Hepatobiliary system is involved.
Why do you think it is liver involvement? Why not it is some hemolytic anemia?
Because there is an appearance of jaundice, and there is also generalized swelling of the body. If it is
hemolytic anemia, the child is in cardiac failure, there is anemia, there is jaundice. What makes you think this is a liver disease? I think this is just some hemolytic anemia. Maybe a G6PD deficiency, somebody gave her something, she had a lot of hemolysis and she is jaundice now.
The age of presentation?
It can be any time, even adults get sometimes.
Drija, is this direct or indirect?
Ma'am, this is indirect.
So yeah, this is hemolytic anemia.
Indirect bilirubin.
What was the color of urine?
Dark color urine, ma'am.
But that can happen in hemolytic anemia also. We just had a patient recently who was also of sickle cell anemia and he had high colored urine, jaundice and abdominal distension. Why is it in sickle cell anemia then? First time presentation maybe, or first time or maybe a late presentation.
Good afternoon. Just a, can you just summarize it, because I just
Yeah.
joined few
Yeah,
minutes.
yeah. Drija, sir has just
Just
joined. Just
the
can you summarize?
chief complaints.
Sorry
Can
for
you
that.
just go over the chief complaints?
Yeah.
Sir, 10-year-old female child named Alaya Sapuriji, Muslim by religion and resident hailing from Gulbarga, Karnataka, born of third-degree consanguineous marriage and first by birth order with chief complaints of abdominal pain and vomiting since 1 month, yellowish discoloration of eyes and skin since 10 days, and progressive body swellings since 8 days.
Okay.
So my question, Dr. Vishnu, to her is, why is this not an hemolytic anemia? Why does she think it is a liver disease?
Correct. So at this point, I think you should be keeping the points open, that we cannot label to a one system, because it is just a 1 month of history. So that means it is something which is not acute, which is going on for a 4 weeks. So it is an insidious onset symptoms. And as you are saying, it is a abdominal pain, then there is a yellow discoloration, and then there is a generalized swelling. So it could be just as madam was explaining, it just a hemolytic crisis. So it could be hemolytic crisis because of hemolytic anemia, because of drugs, because of some liver disease. It could be anything. So at this junction, we should be having an open mind that it could be a just a hemolytic process or just a liver disease. So both things we should be keeping. And as said, madam said, we see couple of patients where people think it is a liver disease, but it turned out to be a hemolytic crisis, and which we call as a hepatitis mimics, and which is very common, which is not uncommon to miss. And it could be something which is a previously missed jaundice, and now the child is just having anemia. So the Krigler-Nazar or Dubin-Johnson syndrome, and then just she is presenting with anemia. So it could be anything. So at this junction, just open the differential diagnosis. It is not the liver disease per se, but what makes you think it is liver, and what makes you think that it is a hemolytic process. So that answers we should expect from you. Okay, why do you think it is liver, or why do you think it is a hemolytic process?
So, if there is a liver involvement, there is a coagulopathy will be seen. Generalized ascites is seen. There is a, because of the, there is a decreased protein. Synthetic function of the liver will be affected.
You are right, Rija, but that you are going retrospectively. See, if you see your constellation of signs and symptoms, not signs still, symptoms, it's not pinpointing, as sir is rightly saying, towards the liver. Okay.
Yes.
It can be any other infectious disease which can present like this, or any other hemolytic. Okay. Yeah.
So what I would do is what are the pointers towards the in the history or on the history? How do you say it is liver, and how do you say it is a hemolysis? Because in the discussion that was going on, and somebody has pointed you out that in the urine color.
The urine color, stool color, we look for that. If there is any complaint of
Color of jaundice also, Drija.
yes, lemon color, or it is a greenish yellow color.
Then ascites also goes in favor of a liver disease. Then ascites is also there, Drija. You can consider it.
So if I just add up to the what was the discussion. So if the child is predominantly having a severe abdominal pain, which is usually a not feature of any liver disease, a chronic liver disease. Acute patients, acute hepatitis, the pain is there for few days. The pain will not continue for months. Okay. Second point you mentioned about the color of urine. Usually in the hepatitis or any liver disease, the color will be dark yellow. But in the hemolytic crisis, the color will be Coca-Cola color or very dark brownish color. So that history we should expect you to go into the depth and take it from the patient. The third point you mentioned about the abdominal distension and leg swelling. So I would like to know more that this abdominal swelling and the leg swelling started after the child has given any IV fluid, or when the child is showing any evidence of pallor associated or the work of breathing is, and then the child went into the edema and the ascites. And what is the symptomatology? Is the abdominal distension is disproportionate with the edema, or the both things are coming simultaneously? Then I know that this is something which is leading related to either congestive cardiac failure thing because of the low protein or the anemia, or if it is a liver primarily, then the patient will have a abdominal distension predominantly rather than the pedal edema. So that should come into your the points for and points against for the hemolytic crisis and the liver. Okay.
Okay, sis. Continue.
Hospital course, child was admitted with the above complaints in our center in the ward. Blood samples taken and IV saline started. On the next day, child was having difficulty in breathing, irritability, and decreased urine output. Hence, child was shifted to the pediatric ICU for the further management. Some blood products were given and fluid was drained from the abdomen. Some blood exchange was done in the form of dialysis every alternate day for the 3 times. Child's irritability started decreasing and sensorium improved. Vomiting and abdominal pain resolved. Jaundice started decreasing on the skin, but still it was visible on the eyes. Abdominal distension decreased with good urine output and normal sensorium. Eyes examination done in the PICU by by senior ophthalmologist, and special dietary modifications were done. And after all this treatment, child's condition is improved. Past history, there is a history of dengue infection 3 years ago, which required the hospitalization for 3 days, and the child was discharged. There is no documents are available for that.
Bridget,
Yes.
can you put this as dengue, secondary dengue hemorrhagic fever? I know there is no rash, but you have now yourself given there is a history of dengue infection 3 years ago. So can the present complaints again fit into secondary dengue?
Could be.
Can you put it as a differential diagnosis?
Yes, it could
But
be.
then what is against it? Can it be dengue? Can it be dengue hepatitis?
Yes, ma'am, it could be.
That's why we are saying that in your differential diagnosis, you should consider all the past history or everything what is occurred, and then sum it together with the present complaints and give a differential diagnosis. You should never always pinpoint to one particular system, because now you yourself have committed this dengue 3 years ago. Of course, that dengue will not give rise to hepatitis or may not. There may be a secondary infection which may give rise to the present condition. We don't know. Okay.
Family history: father is 32 years, mother is 30 years, and child is born by 3rd degree consanguineous marriage. Child is 10-year-old. No history of similar illnesses or any death in other family members. Birth history: G1, P1, A0, mother, gravida para 1, mother conceived at the age of 20 years. Pregnancy was booked and registered in the government hospital. Mother received iron and folic acid supplementation and appropriate timely ANC vaccines as per guidelines. No history of smoking, alcohol, drug or chronic medications. No history of diabetes, hypertension. All ANC scans were normal. Baby was delivered at government hospital at 38 week of gestation via the lower section cesarean section. Birth weight was 3 kg. Baby cried immediately after the birth. Baby shifted to mother side. Breastfeeding was initiated within 4 hours. Urine and motion passed within 24 hours. No history of an ICU stay. Developmental history: she has achieved all the milestone and she is studying in 5th standard, doing well in the study. She is good in scholastic performance, plays outdoors games with the peers and other cousins. Immunization history: received all immunization in government hospital. till 10 years of age. Feeding and dietary history. There is a child taking the calorie of 1900 kilocalorie with expected of 2000 kilocalorie with deficit of the 100 kilocalorie. With protein taking is 25 gram with expected of 27 gram with deficit of the 2 gram. Socio-Economical History. Father is 32-year-old, 10th pass with a salary of 25,000 per month. Mother is 30-year-old, 7th pass housewife. They are living in a joint family of 8 members, had their own pakka house with close sanitation and 3 bedroom, 1 kitchen and 1 separate toilet, belonging to upper middle class of family according to the modified Kukuswami scale. Summary of the history. 10-year-old girl, only child born of 3rd degree consanguineous marriage, previously healthy, brought with a complaint of abdominal pain and vomiting since 1 month, progressive jaundice with abdominal distension and edema, with acute deterioration of sensorium and decreased urine output, which is suggestive of the subacute liver disease, with probable encephalopathy with renal impairment, which is improved on dialysis, some treatment and dietary modification in a developmentally normal, fully immunized child without any significant past and family history. On general examination, patient is conscious.
Can I just mention, just go back to the previous slide. Okay. So you said a 1 month history of the symptomatology. So why do you say subacute?
Subacute, yeah.
How do we classify acute, subacute, chronic if you have taken this classification?
So, acute is within the within days, subacute is within weeks, and chronic is more than in months. But if we are talking for
this you called as a 4 to 6 weeks, you call as a acute. Anything beyond 4 to 6 weeks to up to 3 months we call as subacute, and more than 3 months we call as a chronic. But this symptomatology or these definitions are very different.
आज आणि उद्या सुट्टी दिली असं पत्र फिरायले माहित नाही. आज आणि उद्या सुट्टी शाळेला असं पत्र फिरायले.
So
मला वाटायला
Kulkarni sir,
आता
please
पाऊस
mute.
असेल तर देऊन टाकू.
Kulkarni sir, mute yourself.
okay, so the whatever we are seeing is the
line
acute
आली ना?
presentation.
हं?
So instead of commenting as a subacute liver disease, we should mention that the acute presentation of illness presented with the abdominal pain and this. So this looks to me a acute liver disease most probably, because there is an encephalopathy and the joint and abdominal distension and disproportionate to the edema. But subacute would be the not a good terminology nowadays. For the exam point of view, I think madam will tell what are the definitions which examiner follows. I am not sure.
Actually, sir, Biraja sir, you're right. Even I was a bit uncomfortable with that subacute word, but I just waited. We don't use that subacute terminology anymore. It can be either acute or chronic. I feel that these are the only two which we follow now. So you should know the definition of a chronic liver disease for that. Can you tell us the definition of chronic liver disease? So would you want to, would you want to put this as acute or chronic? First, let us be clear about it. Is this acute or chronic?
ma'am, it is an acute presentation now.
1 month. Okay, then what is the definition of chronic liver disease?
Liver dysfunction for more than 3 months.
Yes. Sir, would you like to say something, Vishnu sir? Are you okay with that? Because I feel the definition is still inadequate.
Yes, I think acute illness is what we say. It is not acute liver disease or a chronic liver disease. Even your chronic liver disease can present like acute hepatitis, acute presentation of liver failure, or they can be a subacute. So the acute viral hepatitis is a different thing. A chronic liver disease is a different thing. You cannot label chronic liver disease depending on the duration. That should be very clear. Acute viral hepatitis is very clear. There is a prodrome, then there is a jaundice, and then there is a resolution over a period of 2 weeks. So if there is a no resolution over a period of 2 weeks, so possibility of acute viral hepatitis is less likely.
Yeah.
But it could be acute hepatitis. But I'm talking about acute viral hepatitis, which we commonly say because of the hepatotropic viruses.
Yeah.
So non-hepatotropic viruses has a different natural history altogether. It depends on the etiology. Like nowadays we are seeing adenovirus. We see commonly now last 2 months we see EBV virus also. So the history is typically different than the acute hepatotropic viruses. So what we can comment on is the acute hepatitis or acute presentation of the liver disease. Okay, that liver disease could be a acute viral hepatitis, acute non-hepatotropic viral illnesses. It could be dengue, like madam said. It could be like a typhoid. It could be leptospira, or it could be a first presentation of chronic liver disease, or it could be a hemolytic crisis because of n number of reasons. Okay.
General examination. Patient is conscious, alert, and responsive, oriented to time.
I just have a and then clarification if I'm wrong. So fulminant hepatic failure is defined as there is no past history, but now comes with fulminant liver failure, and from within 8 weeks. 8 weeks. The second one is that from the onset of jaundice till encephalopathy. If it happens within 7 days, then it is called hyperacute. If it happens within 28 days or 1 month, it's called subacute. And if it is 72 days or something like that, then it is
acute and subacute. Hyperacute,
yeah.
acute and subacute. Yes.
Hyperacute, acute, and subacute. That's right.
Correct.
So this actually, there is a reference for what I'm trying to say.
Yes. This was the classical case of acute liver failure. We know hyperacute, acute, and subacute. In hepatitis,
and then they try to relate it to the appearance of jaundice to encephalopathy.
Correct. So that is for the acute liver failure. This is a hepatitis form. So in hepatitis form, there is no definition of acute, subacute, or chronic. It is an acute presentation. It could be acute because of the viral, non-viral, or a chronic liver disease presenting as a first.
Or maybe anything, regardless of that.
Yes.
In pediatric, we call it chronic if it persists beyond 6 weeks, except for hepatitis B.
Okay, Mishra.
Usually anything above beyond 6 weeks, except hepatitis B, where we take 6 months as for chronic. Because we have seen many patients turning out to be a chronic disease before 6 months. We don't copy adult disease. Adult definition is not copied here in pediatrics.
6 months, no one has said 6 months.
What I really feel is the standard categorization of acute, subacute, chronic is not fixed. There are no clear-cut definitions which can include any organ disease. So what she told initially is appropriate and acceptable. So acute is in few days, subacute is in few weeks, and chronic is in months. That's the approximation. If you go to various references, you will find different cutoffs. So that's why that seems to be acceptable to me.
I think that's so good.
So what should be the final verdict? Let's all students have final verdict. Vishnu, you tell us what is acute liver disease and what is chronic liver disease and what is acute, hyperacute and subacute fulminant hepatic failure. You define it once for all.
Yeah. So one thing is clear. There is a hepatitis form or non-hepatitis form. That is one. Second is you categorize the acute, subacute or hyperacute only in patients with acute liver failure. For the hepatitis form or for a jaundice purpose, you cannot have a one definition for acute, subacute. So if there is acute liver failure or fulminant hepatic failure, what we say is the hyperacute that madam said between 0 to 7 days. If there is an encephalopathy and jaundice duration, so you have a jaundice and encephalopathy within 7 days, then we label as a hyperacute liver failure. If there is a jaundice and the encephalopathy comes between 7 days to 28 days after the onset of jaundice, then we label as an acute liver failure. If there is an encephalopathy after 28 days appearance of the jaundice, then we label as a subacute liver failure. Okay. So this definition is clear for the acute liver failure. For the presentation, we never say it is acute, subacute, or chronic. Chronic is only, as Dr. Mishra sir said, only chronic definition clear cut is for the hepatitis B. So if your HbS positive more than 6 months, then we call it as a chronic hepatitis B infection or disease, depending on the lot of combination of the test which we do. But for the other purposes, only remember that is it a hepatitis form or it is a chronic liver disease form or a portal hypertension, which is the presentation of this illness. So for this patient, I would say it is the acute onset jaundice with some hemolysis with deterioration in form of ascites, predominantly over the edema. So there is a possibility of underlying chronic liver disease, because you don't expect ascites in acute viral hepatitis or any acute illness of the liver disease. So this is how I have put acute presentation or a chronic presentation, that's all. But there is no clear cut cutoff days wise or weeks wise. I think it might have cleared to many.
Yes, sir. Yes, sir. Very good clarification. Thank you. So can we move forward?
General
Yes,
exam.
yes.
General examination. Patient is conscious, alert and responsive, oriented to time, place and person, lying down in supine position on the bed with right intrajugular venous line and left femoral line in situ. Vitals. She is afebrile with the axillary temperature of 98.6 Fahrenheit. Pulse rate is 80 beats per minute, regular in rhythm, normal volume with no radial or radiofemoral delay. All peripheral pulses and central pulses, they are well palpable. Respiratory rate 28 per minute, regular, thoracoabdominal. Blood pressure is 106 by 68 millimeter of mercury, measured in the right arm in supine position by the non-invasive blood pressure method, which lies between 50 to 19 centile. Capillary refill time less than 3 seconds, and saturation of oxygen saturation 97% on room air by pulse oximetry method. Pallor is present, icterus present, no clubbing, no cyanosis, edema, pitting time of edema at both lower limb and periorbital edema, no lymphadenopathy, JVP not raised. Anthropometry, the weight of the child is 25 kg with expected of 32 kg, which lies between 10th to 25th centile. Height is 133 centimeter with expected of 138 centimeter, which lies between 25th to 50th centile. BMI is 14.3, mid-parental height is 162.5 centimeter, upper segment, lower segment ratio is 0.9, arm span raised to height is 0.9, abdominal girth is 62 centimeter, tenor staging, thalaki and pubic hair both are in the pre-pubertal stages. Head to toe examination, head is normal, no frontal bossing, hairs normal, eyes, conjunctiva and cornea are normal, icterus is present, media clear, KF ring is present, no pitoid spots, no dryness of eyes, no cataract. BCG mark present on the left deltoid. Nose, ear and mouth normal, no dental caries, bones, joint and spine normal, hernial sites intact and genitalia, they are normal. Systemic examination, I would like to go to the GIT examination. Inspection done in the supine position with the flexed hip and child lying down comfortably. Abdomen is distended with flanks are full. Umbilicus is transversely stretched. Dilated visible veins are seen. All 4 quadrants are equally moving with the respiration. No any visible pulsation or peristaltic movement are seen. No any visible scars, stria, pigmentation, stoma and injection sites. Genitalia is normal. Hernial sites are intact. Palpation. Abdominal distension is confirmed by the palpation. Venous flow, it is in unidirection in upper part of abdomen. Superficial palpation, on superficial palpation, abdomen is warm, non-tender, no guarding, no rigidity or no rebound tenderness seen. On deep palpation, abdomen is non-tender, distension more in the flanks in the supine position. Palpation of liver, liver is non-tender, palpable 2 centimeter below the right costal margin in right mid-clavicular line. firm in consistency with normal edges and smooth surface, non-pulsatile with the span of 11 centimeter, and left lower lobe is not palpable. Left lobe is not palpable, sorry.
So
Spleen,
the liver span is increased, right? As per her age, what is expected liver span?
ma'am, 8 to 9 centimeter,
So here it is 11
11
centimeter.
centimeter.
Can I ask you something about the anthropometry of this child?
Yes, sir.
So you said 25 kilos at 10 years. So is that normal compared to the height? Do you think the weight is less? Plus this child is likely to have some edema.
Sir, weight is less. So actual weight will be more or less because there is a edema. It will be the weight gain, but actual weight of the child will be less than the 25.
Yes. So what do you think? What is the reason for this weight?
So chronic underlying process is going on, so that's why the weight is less. Because nutrition of the child is good. Matlab, she is taking dietary calorie and protein intake, they are good.
Okay.
How much height you said?
133 centimeters.
Go back to that slide, no?
So why did you say chronic?
Because the height is 5 centimeter less than the actual expected height.
But she's not below third centile, no? Still.
No, ma'am, not below third centile.
And do we have the trends of her height?
No, actually, that previous documents, there is no any previous measurement of height.
If they were available, then how would you interpret that? How will it help you? The trends, old records.
We have to monitor each and every point. The height is, if it is a less than third centile or if it is crossing the 2 centile line, then it is a failure to thrive. But the child is not gaining the proper height.
So
If
what
you
I'm
had the
trying-
growth chart, yeah, you can you say what is the onset of the disease based on the growth chart?
Yes, sir. But yes, we can say that for that we have to have that previous, at least one previous reading of the height to monitor the process.
Okay. So certainly, this child is underweight, 25 kilos, but likely much lesser. And the height has suffered, but not to the extent as the weight. So that tells you that this is not like going on since the age of 5 years or 6 years, isn't it? It is relatively, it is recent. When I say relatively recent, it can be months also. Okay, so you're looking at anthropometry from that point of view, so as to estimate when did the disease start. That is the point, isn't it? You also said that you could see KF ring.
Yes.
Am I right in the general examination?
Yes, sir.
How did you know it is KF ring? What are the DDs of KF ring?
And was the KF ring seen by you or was it picked up by a senior any ophthalmologist?
Ma'am, it was picked up by the ophthalmologist, but the ring was visible by torchlight examination.
So as sir
Okay,
is
yes.
asking you, can you give us a differential diagnosis of such a ring if it is seen by naked eye examination also? Torch. By shining a torch?
And for the proper examination, we have to do the slit lamp examination.
Yeah. So if you see such a ring, what could be the differential diagnosis? Can you enumerate, describe the ring if you have seen by a torch, like what is the color? KF ring seen, that's all what was said over there. So you should have clarified whether it is been seen by torch or a slit lamp examination, what is the color, what is the typical color, and what is the differential diagnosis of any ring which is seen, like for that matter.
It was a greenish brown in color, and the differential diagnosis of the KF is like cryptogenic cholestatic is.
Yeah.
It is also seen in.
So cryptogenic is the last thing you would say, isn't it? Before that, you would say what is known. Cryptogenic is when you know there is a cause, but you don't know cause, isn't it?
Yes. Wilson's
Yeah, but so that is the last thing you should say. If idiopathic, cryptogenic, these are reserved at the very end. when you exhaust your list of possible DDs. So which are the diseases where you will get a KF ring? Is it unique only to Wilson disease, or can you see it in other diseases? Which are the rings that can look like Wilson's, but they are not Wilson's? Naked eye, you can get fooled sometimes that, this looks like Wilson's, but may not be Wilson's. So what are the other kind of rings you can get in the eye? What will you see in old people if you see, the eyes of very old Arcus senilis, isn't it?
But sir, it
Yeah.
is good age.
Yeah, I'm not saying in this child. So I'm asking you, what other rings would you see in other diseases, or physiologically, what other rings are possible?
So Arcus senilis is the same.
Correct. What else? There are many other rings, isn't it, in the eye? So why is the ring formed? Do you know why is this ring formed?
So because of the copper deposition in the Desmond membrane of the cornea.
Correct. So which are the other diseases in which the copper can get deposited in the eye, in the Desmond's membrane?
So
Okay, you read about it, isn't it? So if there is any condition where there is a hepatic copper is increased, you would get this KF ring, isn't it?
yes.
Yeah, but if you have a liver disease and you have a KF ring, then you have almost cracked the diagnosis, isn't it?
What is pseudo KF ring? Have you heard of in this terminology, pseudo KF ring?
No.
Okay, you should read a bit about KF ring now, because your case is now, we are going towards a specific diagnosis, so you should be ready with that. Okay, find out what is pseudo KF ring. Fine.
What is the full form of KF ring?
Casual Fleischer ring.
Okay.
Okay, go further.
Spleen is non-tender, palpable 3 centimeter.
So I have a question for you. Do you get these KF rings in aceruloplasminemia or Menkes-Kinkes hair disease? Vishnu?
Yes.
I have 2-3 patients of Menkes-Kinkes, but I didn't got the KF ring there.
You did not get it.
Basically, corneal rings are common in any chronic liver disorder. So corneal rings generalized can be related to any liver disorder. But when we say KF ring, it's very specific and well defined one.
Okay. Chalo. Drija? Go ahead.
Spleen is non-tender, palpable 3 centimeter below the left costal margin towards the umbilicus, but not reaching up to it with smooth surface. Splenic notch is palpable, firm in consistency, and it moves with the respiration. Kidney palpation not done due to the ascites, but there is no renal anger tenderness. Percussion, liver span is 11 centimeters. Shifting dullness is present, but there is no fluid thrill. On auscultation, bowel cells are heard and no bruits over the liver and spleen. In CNS examination, I'd like to go through CNS examination. The higher functions were normal. There was no neurological deficit, and child was fully oriented to time, place, person. She was talking and responsive, alert. Respiratory and cardiovascular examination were normal. It was not contributory.
What are the features of when you see KF ring? What other features you will mention on the general examination, or any patients of liver disease? What other things you need to mention on the general examination or the specific neurological examination? You have to mention it. Okay, this is not there or this is there.
Sir, is there an astraxis, chorioathetoid movement? Any on the examination, no, sir?
On examination, yes.
So there was no astraxis or flapping tremor, no chorioathetoid movement or no change in the tone of muscles. There are no Palmer erythema or spider nevi or caput medusae.
What about the face? Is it mask face, triangular face?
Or any dysmorphic features of the face.
Particularly mask-like face, you have to mention. Parkinson's like.
Parkinsonism, like, or extrapyramidal.
And invariably in these patients, you will get the Parkinsonism like face or a mask like face. And that also adds to your examinations. But you have to mention, when you are mentioning CNS examination, no neurological deficit. Instead of that, I would be more interested in
Any signs?
Signs of?
Signs of the CNS manifestation, neuropsychiatric manifestation.
You said this child had an encephalopathy and now it is improved. So I would like to know, how did you examine the encephalopathy at present, or to rule out or to rule in? So what are the things you have seen or did with this child?
For the sensorium, behavioral abnormalities, is there any, is there or not? Change in the sleep-wake cycle, is there emotional ability, and on the examination, we can check for the tone power.
10-year-old child, I would expect two more things from you while you are
Talk
examining.
about the higher functions, Drija.
Higher functions were normal, sir.
You tell the components and how did you examine? That's what sir is trying to ask you.
Sir, child was conscious, oriented to time, place, person. Memory was normal. There was no emotional ability.
But how did you ask those questions? Is what he's trying to ask you.
So for the memory, I have asked her ki, what have you eaten in the morning, or in the breakfast, what have you taken yesterday, what he has taken, and asked for her birth date. And she is recognizing the parents to the doctors, where is she, and what is going on surrounding her. Speech was normal, sir. She was able to understand and she was able to answer correctly to my commands.
Okay, and what about the extrapyramidal symptoms or the signs you have seen or asked for specifically?
So, change in a tone or any abnormal movements.
So how do you come to know change in tone? Means, is there anything you will do?
Yes, sir. Outstretch the hands, and there is a hyperextension of the wrist, and seeing for the any flapping tremors or not, or any choreoathetoid movements at the wrist.
So how do you come to know choreoathetoid movements if there are very, not but obvious, but if something you need to tell them to do? There are two things which we try to do when we see the adolescent age group. One is the daily handwriting.
Yes.
Okay, so you need to have a handwriting of the child. The second thing which we ask is
making twist.
Yes.
1 to 25, we have to join them.
Yes.
They have to tell them to join 1 to 25 numbers.
And you have to mention that when you are telling that the child had encephalopathy before, and now you have to make sure that within how much second they have completed it. And when you are talking about the memory loss is, if the encephalopathy is for the longer duration, then there will be memory loss of maybe long-term memories, or the mid-term memories will get lost. But if the child is encephalopathic for a longer duration, then they will have the problem with the apraxia or dyscalculia or something like that. So that also you need to take that 10 plus 20 or the subtraction addition, and you have to mention that. You just have to mentioning about higher function normal. If this child is not having encephalopathy, then I would agree that okay, the CNS is okay. But if the child is encephalopathic, then you go depth-wise, go in depth and mention that point.
You know, in adults, they use this mini mental status examination.
MMs.
So for adolescents, it is almost, you can use it.
Yes.
Drija, how long
Rajesh, can you explain that mini mental status? Dr.
There are
Rajesh?
several components to it. Yeah, there are several components to it. So what they do is at the beginning of the interview, they would tell you to remember like 2-3 things. For example, they will say the name of a color, maybe a everyday object. So like this 3 or 4 things they will tell, and they will tell you that you remember this. I'm going to ask you after 15 minutes. So at the end of interview, you again ask those. So what did I tell you? What did I ask you 15 minutes ago? That's like a test of immediate memory.
Oh.
There are components. This is not the only thing, but there are many components of it, which are again simple addition, multiplication. These are also there in it. For adolescents, we can use it. It is very useful.
Would it not be easy to just say that which stage of encephalopathy she is and use those criteria?
Yes, it is possible. But if you want to monitor in bigger children, you could stage the encephalopathy. Younger children, we have a problem. We know that. But in older children, if you want to monitor any neurological dysfunction, then this is useful. In adults, they use it primarily to see, if they have some of these Alzheimer's or these kind of disorders where there is a lot of memory disturbance. They use it to keep a tab on that. So to monitor the progression. But if you have, for example, something like a SSP patient, where there is progressively the child goes downhill, or any gray matter disorder, even there you can use these kind of scales.
Brija, how long is she under treatment in the hospital?
Ma'am, 1 week.
1 week is done. When would you expect the KF ring to go? Do you know that the KF ring, does it stay permanently or it goes off?
After starting the treatment, it can disappear after the 3 years.
Yeah. And can it reappear again?
If the child is not taking the proper treatment or they discontinue suddenly.
Discontinuation. Yeah, discontinuing the treatment, it will reappear. So what is your final diagnosis? Have you done with the systemic examination CNS? That's all. I mean, perfectly normal, nothing in the CNS?
No, ma'am, because she was having the irritability. So she was shifted to PICU, and the dialysis was done to, when I examined the child, it was, she was fully oriented. She was knowing everything. So there is no such CNS findings.
Okay, you can tell your diagnosis. Would you go? Yeah.
Summary: a 10-year-old schoolgirl, only born of third-degree consanguineous marriage, previously healthy, brought for the abdominal pain and vomiting since 1 month, progressive jaundice and abdominal distension and edema with acute deterioration of sensorium and decreased urine output, suggestive of the acute presentation of some liver disease with examination finding of pallor, icterus, bilateral limb and periorbital edema, KF ring in the both eyes with hepatosplenomegaly and ascites. Most likely, it is an acute presentation of some chronic liver disease with probable encephalopathy with portal hypertension in the form of firm splenomegaly. My diagnosis is Wilson's disease.
So the only positive, or what would we say would be the finding is KF ring, on the basis of which now we have to accept it as a diagnosis of Wilson's disease. Suppose in this case, we wouldn't have got a KF ring. Your probable differential diagnosis, just minus the KF ring and try to sum up the features now.
So, ma'am, I would take the differential diagnosis.
Yeah.
It could be chronic active hepatitis.
Why chronic? Because what other than positive findings which you are telling? I mean, you're telling us chronic. Why? Because you just said it is a suggestive of acute liver disease, because that subacute thing we removed now.
Yes.
Isn't it? She
What are
came
the
with
other causes that the
abdominal
Wilson-
pain, vomiting since 1 month, progressive jaundice with abnormal distension and edema. Okay, sensorium also, yes, there could be some deterioration of sensorium. I am just saying, just keep all the findings and minus the KF ring. So what is the diagnosis?
What are the other causes of chronic liver disease? That is what madam wants to know.
Autoimmune hepatitis.
Okay.
Okay.
If I will give you the story like this child is presented with abdominal pain and vomiting with distension and a little bit of jaundice, and the child is having the same thing except the KF ring, but jaundice is less. You say deep icterus in this child, na?
Yeah.
So I will say that jaundice is less. So what will be the third common differential of chronic liver disease? One is Wilson, second is autoimmune.
As a storage disorder.
Before storage, ascites.
Total.
Child presented with the abdominal pain and distension first, and then you would notice the jaundice little bit.
Tense ascites.
We are giving you so many hints. You must have seen so many cases in KEM.
Okay, you talked about storage disease. Which storage disease you are thinking about?
So, glycogen storage disease, tyrosinemia.
Okay. What else?
Niemann-Pick.
Niemann-Pick. Okay. So let me tell you the natural history of all these three diseases. Niemann-Pick disease will start in the infancy, and by 2 years they will have a neurological deterioration, and the liver disease probably will not trouble more. It is not the liver failure or portal hypertension which will set in. The glycogen storage disease, only disease which can present with portal hypertension in first decade of life is only GSD type 4. Rest all the GSDs, particularly GSD type 3, 6 and 9, they present with a cirrhosis in second or third decade if they are not taken control of. The tyrosinemia usually presents in infancy with the liver failure in majority of the cases. Some of the cases can present later up to 2 years or 4 years, but I have yet to see a patient beyond 5 years with a diagnosis of tyrosinemia. Whatever the disease progression or the disease symptomatology or the presentation, usually in first 2 years of life. So all these three differential will not be there.
EHPU.
EHPU is not the liver disease. So because you utter the word of EHPU, so tell me about what do you understand by pre-sinusoidal, sinusoidal and post-sinusoidal?
So in
It's some disturbance going on. Hello.
Pramod, you have to mute yourself. Some disturbance is coming in the background.
Yeah, he's muted. Muted, madam. Yeah. Yes, Rija, what is sir asking you?
So ascites, jaundice and portal hypertension, we have to look for it. In the post-sinusoidal causes, pre-sinusoidal causes, there is an obstruction. So there is a appearance of the portal hypertension and features of the ascites.
What?
Like varicose bleeding will be there, history of bleeding.
Where is the problem? Pre-sinusoidal means obstruction of what? What organ or what?
So before the sinusoidal spaces in the liver,
Obstruction where?
it could be in the splenic
It could be in splenic.
It could be in the splenic vein
Okay. And
or portal vein, extrahepatic part of portal vein.
if it is the intrahepatic part of portal vein, what it is? Is it sinusoidal?
So yes. Before the sinusoids, it is a pre-sinusoidal cause.
So intrahepatic portal vein is a sinusoidal or pre-sinusoidal?
So it is a sinusoidal.
No. Intrahepatic portal vein is also a pre-sinusoidal. Even your portal fibrosis is also a pre-sinusoidal, like a congenital hepatic fibrosis, non-cirrhotic portal fibrosis. These are all pre-sinusoidal causes. Sinusoids means where the hepatocytes are arranged, and in that sinusoids, if there is a problem, that disease we call as a sinusoidal. So what are the classical causes of sinusoidal problems?
If there is a
Disease. Which?
hepatitis.
Hepatitis, like any chronic viral hepatitis.
Or
Autoimmune. These are the sinusoidal problems. Okay. And what is post-sinusoidal?
After the sinusoid, like there is an obstruction to the flow, like veno-occlusive disease or any constrictive pericarditis, congestive heart failure.
And the
So
common
Burchiari.
Burchiari. So in Burchiari, where is the obstruction?
Yeah, in the hepatic veins.
Or
In the joining of a hepatic vein with inferior vena.
okay, joining, it is up to the IVC, up to the heart. So that is a post-sinusoidal. So pre-sinusoidal, you just clear that key, even up to the hepatic fibrosis and non-cirrhotic portal fibrosis, it is a pre-sinusoidal. So what is the difference of presentation of pre-sinusoidal disease, post-sinusoidal disease, and sinusoidal disease?
So post-sinusoidal causes, they are present with a portal hypertension, ascites, jaundice.
So what is the difference between them
of the
sinusoidal?
Sorry?
Liver size and liver feel, you can tell us.
So liver will be enlarged, smooth.
So what is the difference between sinusoidal, post-sinusoidal, and pre-sinusoidal presentation? In pre-sinusoidal, because liver is not involved, the patient will only present with portal hypertension, but that portal hypertension is predominantly a variceal bleed rather than the ascites. Okay, so ascites is very rarely come in the extrahepatic portal vein obstruction. In post-sinusoidal disease, jaundice is minimal, ascites is predominant. So that is what Dr. Rajesh Kulkarni sir also wanted to give you the hint. If the patient had a tense ascites and minimal jaundice, so what would be the first differential diagnosis we thinking? Burchiari. In sinusoidal disease, the jaundice, ascites, and other things go simultaneously. So jaundice is predominantly in the sinusoidal. And that is why we need to have the differentiation, that how the presentation is there, that is where we come into. So with this presentation, most likely liver disease, a sinusoidal problem, a chronic liver disease. So what are the stigmata of chronic liver disease?
So there is a palmar erythema, spider nevi, present caput medusae. So because of these features, there is a stigmata.
And
it is a girl, but if it is boy, then gynecomastia.
And
Dupuytren's contracture.
Okay. Go on.
Yeah.
Any other?
Vishnu, correct me if I am wrong, but Dupuytren's I think is common in alcoholic liver disease.
Yeah,
Yes.
Dupuytren's contracture we never get here.
Yes, yes. No, I was just trying to get few answers from her. That's why I didn't commented in between. So anything else you missed, or you think that you should mention again?
Portal hypertension with varicose bleeding will be there.
No, stigmata of chronic liver disease is different. Portal hypertension is different. Varices is different. So when I tell stigmata means it is very specific to that. Varices is not the stigmata of chronic liver disease. It can present in a portal vein obstruction also.
Clubbing will be there.
Sorry?
Clubbing.
Clubbing is also not a feature of CLD, because clubbing can happen in any other disease also. So it is never a stigmata of chronic liver. When you call as a stigmata, that means very, very specific to that disease only. It will rarely be seen in other diseases. So telangiectasia is more common than any other problems, and your palmar erythema. But palmar erythema is again a very soft sign which we will see. Testicular atrophy or gynecomastia is more than adolescent age group, not in the lesser age group. What else you said again?
Spider nevi caput medicine.
Spider nevi caput medicine. Is the splenomegaly enough to call as portal hypertension? So what is the definition of portal hypertension clinically?
There should be visible vein. There are prominent veins were visible. There was ascites. Varicose bleeding mostly will be there.
So the combination of three, if the 2 out of 3 are there, the chances of portal hypertension is more. So remember that ascites, splenomegaly, and varicose bleed. If 2 out of these 3 are there, then we label as a portal hypertension. Just on the basis of splenomegaly, probably to label portal hypertension is the chances of having portal hypertension is less. But if the varices, if there is a splenomegaly and ascites, the chances of having a portal hypertension is more. It is not a classical feature, but clinically you can suspect more. But what is the proper definition of portal hypertension?
Any ultrasound, USG?
Ultrasound changes, yes. Portal vein, we have to look for the portal vein diameter for that.
Yeah.
The USG.
What is the cutoff in children?
I don't know.
9 millimeter. In adult, it is 12.5 millimeter. In the children, 9 millimeter, and in infants, we take even the 8 millimeter as a portal hypertension. So if this child comes to you first time, what will be the first test you will do? Second, third, fourth, fifth?
Sir, first I will do the hemogram for looking at the HB and the total leukocyte count and platelets count. Then LFT with PTA-PTT INR to monitor the liver function test. Specifically look for the proteins and albumins, bilirubin level, SGPT, SGOT level. Then RFT, because the patient was on the deteriorating and decreased renal urine output. So I will monitor the RFT and electrolyte. And next, I will go to for the USG abdomen. For there was a ascites was present and difficulty in breathing. So USG, and I would like to do the ascitic tapping. If it is mild tap to USG guided, and I would like to send for the diagnostic step. If it is a severe ascites, then for the therapeutic step, I will do. So for the, I will do the eye examination. If it is a Wilson, there is a present of KF ring. If other storage disease, then it will be the cherry red spot or anything. I would look for that. I will like to further 24-hour urinary copper and serum ceruloplasmin level. And if the diagnosis is it's not made specific antibody test, and for the liver, if it is not made, then the liver biopsy, the last. And if the liver biopsy is not confirmatory, then like for the molecular testing.
Okay. So if I give you the some reports, just comment on that particular report. So let's see, the liver function test is showing a bilirubin of 3, a direct component of 1.8, SGOT and SGPT, SGOT of 130 and SGPT of 90, the total protein of 5.2, albumin of 2.1, alkaline phosphatase of 500, GGT of 200, and PT-INR is around 1.4. So what do you infer on this report?
So there is a raise in the direct component of the bilirubin, and INR is raised. So there is a defect in the coagulation function of the liver. SGPT, SGOT raised, but not more than 3 times of the upper normal limit.
Don't you ask about clinical history? See, you should never interpret
Yes.
it without clinical history.
So the first question I would expect from you that what is the age of the child and why the child is done the liver function test. Okay. So whenever it is asked, because the newborn is different, the toddler is different, then the adolescent is different. So let's say this is 5-year-old child presented with a jaundice of 3 months of duration and hepatosplenomegaly.
So only the complaint was only jaundice.
So I just want an inference that what is wrong in this report.
Sir, I would like to know the hemogram.
Hemogram is platelet of 2.25, the TLC is 6,700, the hemoglobin is 9.5, MCV of 78.
And so there is any history of fever or anything?
No.
Then sir, there is a hemolysis is going on, and so that's why there is a rise in the bilirubin level. It could be some hemolytic anemia. Sir, any positive family history was there?
But
No.
What was the albumin and total protein?
Albumin was decreased, so liver synthetic function was decreased. It was affected.
So what I wanted answer is like, this is like what madam has pointed out. There is a little bit of coagulopathy. The proteins and albumin is less, particularly albumin is less, and SGOT, SGPT is not more than 3 times. So something is happening chronically. Probably this is a chronic liver disease. Okay. So let's see another example which probably fits into this child.
Report of dengue.
Report of dengue, but I gave the history of 3 months duration.
Okay.
So,
Okay.
yeah. So let's concentrate on this child. Probably I would say the bilirubin is 35, direct fraction is 22, the SGOT is 46, SGPT is 38, the total protein is 5, the albumin is 2.4, alkaline phosphatase is 78, the GGT is 120, and PT-INR is 1.78. So what do you infer? A primary inference.
So biliary part of the hepatobiliary system is mainly affected. There is not mainly the liver hepatocytes, they are affected. But there is a problem is going on the biliary.
So the current problem is the bilirubin. But with this history in your background, that this child, 10-year-old child, presenting to you with the jaundice, abdominal distension, and still the SGOT, SGPT is not high. So what do you infer from that?
Synthetic function of the liver is still.
But suppose the liver in this case was not palpable, then the same investigations which Viradhar sir has told, and liver is not palpable, or only left lobe is palpable.
It could be cirrhosis.
So that means already there is very few hepatocytes which can get damaged. So the hepatocyte mass is not there. Lot of this liver is because of the fibrosis. And why the bilirubin is high? 35.
Conjugation, because of there is not all hepatocytes are functioning. The conjugation process is not going on.
But it is the 35 with a direct fraction of 22. So conjugation is happening.
With anemia.
Yes, hemolysis is going on along with.
So any bilirubin more than 13, when you think about that, or maybe more than 17.5, so the hemolysis is the one of the reason of high bilirubin, and the causes of hemolysis could be.
It could be hemolytic anemia, congenital or acquired. If it's congenital, then present early in the life, it's like the hereditary spherocytosis, thalassemia or sickle cell. If it is acquired, then autoimmune hemolytic anemia or chronic blood loss is going on somewhere.
Or your copper also can lead to a hemolytic. Good.
Dr. Vishnu, I wanted to ask you, just now we spoke about left lobe of liver being palpable. So what is the importance of left lobe of liver? Because this situation comes very commonly.
Yeah, actually, Dr. Kulkarni is rightly putting it up, because we recently had a patient of severe iron deficiency anemia, no other cause found. She had a hepatosplenomegaly and left lobe of liver palpable. What could be the cause? It was a pure nutritional anemia.
So whenever we see left lobe of liver is palpable, blindly I would say we have to rule out underlying chronic liver disease, because that means the left lobe is enlarged and there is a fibrosis, and that is why we need to rule out the chronic liver disease. So any left lobe enlargement, chronic liver disease has to be ruled out. There is no doubt about it.
What I have learned from some people is as follows, that whenever there is a chronic liver disease that goes into cirrhosis, the liver shrinks. And as the liver starts shrinking, the left lobe has nowhere to hide, while the right lobe goes under the costal margin. And that's why left lobe remains palpable while right lobe disappears.
Absolutely.
This is what I learned from some of my seniors.
Correct. Absolutely. So that is why the fibrosis sets in. That means left lobe is palpable. That is a cirrhotic liver.
So that is a sign of chronic liver.
Palpable when there is hepatomegaly. I don't think it has much meaning. But only left lobe is palpable, right lobe is not palpable at all. Then it has got a lot of meaning in the form of shrunken liver, where the left lobe remains palpable because it has nowhere to hide.
Drija, few other differentials I want from you. Can it be liver abscess?
Sir, if it's liver abscess, then it will present like a fever, and the liver will be tender on the touch, on the any movement.
What is the differentiating feature here, which is against liver abscess?
Ascites and that one.
Jaundice. So it's a liver abscess is a focal hepatitis. So when you get jaundice, it is generalized hepatitis. Any other differential, any congenital anomaly, any acquired other organ disease which can come with this presentation? Acute abdominal pain, vomiting, some distension in epigastrium, some jaundice. Any anatomical issues? And ultrasound picks up the diagnosis. CBD is not visible.
The biliary.
CBD not visible. Ka?
And a cyst there in epigastrium.
Pseudopancreatitis.
Yes. Anything more? When CBD is not visible? What is choledochal cyst? Can it present at this age?
Yes. But the presentations are present early in the life.
Not necessarily. It can present at any age.
So how will you manage this child, this particular child? How will you manage now? You have all the investigations, and we agree that this looks like a chronic liver disease, like a Wilson. How will you manage this child now?
Choledochal or
So, child was in the encephalopathy. So first we have to manage the encephalopathy part. And the bilirubin was very high, and there was decreased urine output. So we can do the dialysis for it to improve. We can give the IV fluids, but if it's not improving, then we can do the dialysis. For the treatment itself part, we have to start the chelating treatment or the
Plasmapheresis, beta. It was plasmapheresis.
plasmapheresis or for hemodialysis. And we have to
Any
start.
drugs you can use? Any drugs you can use if the child is having a hepatic encephalopathy?
Rifabut
Okay.
and N-acetylcysteine.
What will do? What will rifabutin do?
Sir,
It's an antimicrobial, isn't it? What will it do?
yes, it will.
I feel it is rifaximin, not rifabutin.
Sorry, rifaximin.
Rifaximin, yeah. So, yeah.
We can give.
So it will kill the pathogenic bacteria that produce ammonia, isn't it?
Yes.
Which other drugs will you use?
N-acetylcysteine.
Lactulose?
Lactulose.
Drija,
There is a feature of the raised ICP, then we can manage. We can start the 3% NS.
Yeah.
Drija, this buildup of copper which is occurred, how will it also affect the other organs and cause some other manifestations?
Ma'am, because copper will go into the other organs and it will deposit in that organ. Like in the eyes, it will deposited in the cornea. So we will see the KF ring. It will go to the brain and affect basal ganglia. So we can see the tremors. It is a clinical manifestation of that part. It will deposited in frontal lobe. So neuropsychiatric manifestation will be seen. In the kidney, it will go and affect the proximal convoluted tubule. So features of Fanconi anemia will be seen, and it will destroy the RBC membrane. So there is a features of the Coombs negative hemolytic anemia.
Renal tubular acidosis, I think. RT.
How will it affect the bones? Any bone involvement? If it gets
It can come as a fracture sometimes. How?
Arthralgia, yes, and fractures because of
Will cause lack of bone density and premature osteoporosis, isn't it?
yes.
So your treatment, which you just mentioned, will it take care of all this?
No, ma'am. We have to treat the disease part also. As such, we have to start the chelation or the factors which will
Exactly.
decrease the absorption of the copper. We can start the penicillamine or trientine, which will act as a chelating agent, or the zinc, which decrease the absorption of the copper. But child was in the matlab, there is a decreased renal urine output, so we cannot start the D-penicillamine, and so the which we have to start the loading dose, and then on maintenance dose.
Yeah. So for how many years? Lifelong, isn't it?
Lifelong treatment will be there.
And
And
how
it
will you
also,
how will you decide?
sorry,
Adverse effects of penicillamine.
ma'am, it will affect the elastic tissue of the body. It will cause the hemolysis, decrease. It affect the renal functions. So we cannot use if there is a child is in the renal failure. Elastosis will be seen, and 10% people have the neurological worsening with. There was a such record that is 10 to 20% have the neurological worsening with starting with penicillin.
Any specific instruction while giving medicine?
Yes, medicine should take 2 hours before and 2 hours after the meal, because it will affect the absorption of medicines. So
Good.
Vidya, you stop sharing the screen, no?
This child is born of third degree consanguineous marriage, isn't it?
yes, sir.
So what is the implication, or how do you take into account when you are taking a history of a chronic liver disease? Which are the liver diseases that have autosomal recessive inheritance?
Wilson's disease, hemochromatosis, storage disorder, glycogen storage disorder, lysosomal storage disorder, tyrosinemia, alpha-1 antitrypsin deficiency, alkaptonuria. If also lung involvement, cystic fibrosis is also autosomal recessive.
माझा काहीच संबंध नाहीये. डॉक्टर राजेश कुलकर्णी लिहिलं मॅडम.
So anything apart from this management?
तुम्ही मला का कॉल करता?
Very good presentation.
नाही मॅडम, नाही
we
तिथे खाली
have
लिहिलंय ना
to,
पल्मोनॉलॉजी. त्यांचं पण नाव दीपाली आहे, पण आडनाव गायकवाड आहे ना.
counsel that treatment will go on the lifelong, and they won't discontinue the treatment in between, and family screening should be done for the other siblings, for the
Very
parents.
important. Yeah. So this family screening is extremely important. Counseling is very important.
But here only one child is there.
Yes.
So is it necessary? Whom do you want to screen?
Sir, we have to screen for the future pregnancies also, because it is a autosomal recessive. So still there will be chance in the future child that it will.
Can the parents be a Wilson's?
Yes, parents could be can be carrier of this.
They cannot be Wilson.
Can be Wilson. Yes, sir, they can be Wilsons, because some reason might later in the life.
So do you want to screen them or no?
Yes, with siblings and parents both.
So you need a 3-generation family chart, and to see that if there is anything which is a consanguineous again in the family tree, that those children, particularly the cousins, first degree cousins, needs to be screened along with the parents, and to know that if they are having Wilson or not. And this is especially very important because the parents, as you rightly said, that they can present later in the life also with the other problems.
Did we talk about gene diagnosis in this child? I thought we missed
Yes.
that part. When we talked about urine
Molecular
ceruloplasmin and
diagnosis.
24-hour copper, and yeah.
We can do the molecular diagnosis, and there is a mutation in ATP7B gene can be found. There are more than 500 mutations. It could be haplotype or it could be.
Yeah. So instead of doing a biopsy, can you rely on the gene then?
Yes, sir. But yes, sir.
Yeah, because biopsy is
think-
invasive, but
Biopsy-
you try to limit invasive.
I think the diagnosis of Wilson is little tricky, and you need
Multiple testing.
for a simple reason that we advise to do only 3 tests: ceruloplasmin, 24-hour urine copper, and the K-ring examination. And if 2 out of these are positive, then probability of having the Wilson is very high. But in certain cases, it is not possible to get the answer. And in those children, there is something called as a modified Lubzik score. And on the basis of that score, then we try to segregate. And always while doing the testing for the Wilson, you mention specific antibodies, but we always try to do the serum IgGs and the ANA, SMA, LKM1 and SLA antibodies along with that, because it could be autoimmune also, it could be Wilson also, and it is very difficult to in certain cases it is the test, some tests are positive here, some tests are positive there. The genetic has not given more than 1 point in that score, and that to the specific mutations which, or the if it is a homozygous, then it is +2. If it is a heterozygous, then there is +1. If it is positive, then it is only +1. So it is not given much score. The total score required is the 4, and the K-ring, ceruloplasmin, and 24-hour urine copper. These are the 3 primary which got the score of 2. So genetic really not required. Even though we do the test, we all know that it takes at least 1 month or 1.5 months to get the reports. Until that time, we cannot stop the treatment, or we have to do something for the child to make him better. So genetic usually is not there. On hindsight or on the retrospectively, we can definitely say that okay, the genetic added the point, but it is not the test which I would advise upfront to do.
Vidya, how will you long-term monitoring of these patients? How will you do?
Ma'am, we have to keep the child in the follow-up, and we have to monitor the level of the ceruloplasmin,
And only
and
that.
6 monthly for the KF ring.
Any liver test we will keep on doing for the follow-up?
Yes, liver function test, ma'am. We also do the liver function test.
Once you initiate the therapy, what should be the values of copper excretion at the beginning of the therapy?
At the when we start the therapy, then initially the copper excretion will be the highest.
Yes.
It could be more than 1,000.
Yeah.
And then it will
later?
gradually decrease. It's like between 200 to 500.
Yeah, but did you mention in the treatment part about zinc salts? Have they any role in the therapy? Zinc salts.
Zinc, ma'am, it will compete with the copper, and it will decrease the absorption from the GIT.
Yeah, I think forgot to mention about that in the treatment. Zinc also plays a very big role in that.
Yes.
Any other medicine you know about for the treatment of Wilson, which is available in India?
Yeah, one more she also did not say that.
Triantine, ammonium
Yes,
tetra. Yes.
Which one is available?
And all 3 of them.
So triantine is available.
Expensive.
Expensive medicine, so everyone.
So who are the candidates for liver transplantation?
Ma'am, if a child presented with the acute liver failure, or there is a fulminant liver failure, decompensated liver failure, then we have to counsel the parents regarding the transplant.
Yeah, so can you tell us something about that?
Okay, ma'am?
Can you tell a bit about liver transplantation for Wilson's disease?
Ma'am, we have to first counsel the parents regarding the transplant, and they have to find the donor. Donor should be healthy. Matlab, they won't have any diseases. We have to check for their mutation. If the family is going to transplant the liver, and they should not be the Wilson carrier. Monitor their blood test, sugar, HIV, hepatitis, and all that. And we should arrange for the, if the transplant is a costly process, so everyone cannot afford. So
I know. And do all the symptoms
arrange
regress? After liver transplantation, do all the symptoms regress?
No, ma'am, it will gradually take time.
Which symptoms particularly are not 100% sure that it will regress? Most of them do regress, but which of them will not? Despite successful liver transplantation, Drija, many neurological symptoms and psychiatric symptoms may not regress. Okay. I think Vishnu sir is the authority to say. Sir, can you just give us an overview? You must have performed liver transplantation in Wilson's. How is your experience about it?
I think only in the two conditions in the Wilson disease, if the child is encephalopathic,
okay,
or if the child has decompensated so much that doing a plasmapheresis is just a bridge to the transplant. Sometimes we do the plasmapheresis, child improves, we think that it is a candidate for liver transplant, but some of the kids or many of these kids don't require a liver transplant. I would say out of 100 patients of liver transplant was done for the Wilson previously 5 years back. Now only 10% of those children are needing liver transplant. So 90% of these kids, with the advent of plasmapheresis, the CRRTs, and the medical management, they could able to survive without the liver transplant. But those patients who already had an encephalopathy grade 2 or grade 3, these are the children which will not be helped with the help of the plasmapheresis. So those children needs to be sent for the transplant straight away. Otherwise, even I have seen in decompensated Wilson, those children will get back. But the patients where the ascites has been developed, they have been decompensated, they have been in acute Wilsonian crisis. So these are the children, in spite of the plasmapheresis, there is little bit of improvement. So these children needs to be monitored properly, because I see that the patient gets discharged and then land up with the another decompensation and then get expired in spite of the good chelation. So we need to follow them every weekly after the discharge, not monthly or 6 monthly. Those children where we do the liver transplant, the disease is cured, but we used to say that the children with neurological decompensation, they don't revert back. But on the contrary to the newer data is showing, even though you have a neurological deterioration, you do the liver transplant, the neurological problems, some of them gets reversed. So we did the transplant for even the bedridden children because of the neurological disease, and now the children are walking and doing great. So the new thing is that even if you have a neurological deterioration, you can go ahead with the transplant, and that neurological deterioration can get reversed. And a good success rate of more than 95 centers, 95% all across the centers in the Maharashtra.
Thank you, Dr. Vishnu. Great to know that. Yeah.
Thank you. I think we should stop here.
Yes. Nice,
so
good
I think
presentation.
Excellent. Yeah, very nice presentation.
Excellent presentation.
So thank you once again for being here, Dr. Vishnu, Dr. Ambike ma'am, Dr. Oti madam she's always there to support us. Also, Dr. Pramod Kulkarni is always there. So thank you all the dignitaries, and we'll see you in 2 weeks time. Thank you.
Thank you, Dr. Rajesh. Okay, bye.
Thank you, sir. Ma'am, are you there? Thank you to all the faculties. Am I audible?
Yes, Drija, you are audible.
Thank you, ma'am.
Okay, it was good. It's okay. Yeah.